Good evening, everybody, and welcome. I think there's still a few people joining, but I'm going to kick off. Just in case you're wondering what session you're in, this is Ask About Asthma. And we've got an hour to stimulate you with innovations in pharmacy for children and young people. I'm chairing this evening. I'm Steve Tomlin. I'm the director of the Children's Medicine Centre at Great Ormond Street, but basically been a clinical paediatric consultant for many, many years. In fact, that's all I know. So that's what I'm doing here, chairing the session. So welcome. Just in terms of a bit of housekeeping, you will probably notice that you're not up on screen, so cameras are off. Please keep them off. Please keep mics off. That's just so you can see our beautiful presenters and hear our beautiful presenters okay as they're going. Please do put some chat or questions in the chat. If our presenters can answer them sort of during the evening, they might well type in, but otherwise we'll have a question panel at the end of all the sessions. So hopefully the 10-15 minutes right at the end for some chatting. So I'm hoping that all makes total sense. I'm hoping it's going to be a stimulating evening. So please do put some chat in. It's that conversation at the end which sort of brings the whole thing together. So do that. I have the great pleasure in introducing Darush Attarzadeh, who's a clinical fellow respiratory pharmacist and respiratory lead for North West London Asthma Network. Basically, and I believe it has done loads and loads of good things about smoking and all sorts of issues that we've sort of known him for over the years. He is presenting alongside Alison Summerfield, paediatric nurse and asthma senior delivery project manager at Northwest London at Hillingdon. And just need to drop in that she is the named Respiratory Nurse of the Year 2023 by the as a nursing award, which I think is absolutely amazing. So you can give her a little cheer when she comes on if you like. You will be muted, but please do give her a little cheer. So I would like to hand over to the two of them to start their presentation, and hopefully you find this absolutely stimulating. Thank you very much. Darush.
Thank you, Steve. So, well, that was an introduction, and now we've got to follow that, Darush. So, we're going to talk to you a little bit this evening about the PCN pharmacy support work that we've been doing in Northwest London, linking the baby steps to asthma right care. So, starting with the real fundamentals and working across lots of boundaries and lots of sectors to achieve many different things. Next slide, please, Darush. So I'm going to start off just by talking a little bit about our Northwest London Children and Young People's Asthma Network and some of the things that have been happening in recent months in relation to children and young people's asthma care. We've been having quite a number of MDT sessions with paediatric consultants from a variety of the different hospitals, district general hospitals within Northwest London, specialist nurses and pharmacists. And the aim of those has been to discuss challenging cases that perhaps our colleagues in primary care and some secondary care settings are finding a little bit tricky to work through. So it's a real opportunity to bring cases to that forum and have an MDT discussion-based solution, if you like. Which way should we go? What should we do? Lots of work going on within the pharmacy area in terms of support, thinking about baby steps to asthma right care. So starting really with the fundamentals right at the beginning, thinking about the audits and the searches that actually are much, I think, easier to do in primary care than they are in secondary care, and then looking very carefully at that data, progressing and looking over time at what changes we can make from those original searches, and also the safer labelling in relation to particularly the use of SABA inhalers. So rather than it just be a PRN, getting the wording really accurate and correct so that it's clear, making changes on those acute and variable repeat prescriptions, and ensuring that children and young people don't get two Sabri inhalers per prescription is just one very simple example, but can have huge impact, and often starting those very difficult conversations. I think one of the very exciting pieces of work that we've been doing is group consultations. They have been great fun, and we'll talk a little bit more about that, but really fundamentally making big changes within the primary care setting in a very different way. And we've also carried out quite a lot of work over the last year to 18 months in one particular borough that we're hoping to roll out across North West London, with mentoring sessions for pharmacists working within primary care, where we go out and do the do together, if that makes sense. So Darush is going to take things forward now, and I'm going to step back in a little while.
Thank you, Alison, for that. So a lot of exciting things going on in North West London around data, actually, population health management. We've had a lot of good information that we could get nationally anyway, a lot of us from the Business Service Authority, EPAC2. I've been working closely with a lot of the med management teams with regards to getting that data. For example, Alison was talking about the over-reliance of the short-acting beta-2 agonists, and also underuse of preventative treatment in children and young people population as well. We could get that data. But the London Asthma Decision Support Tool has been something that a lot of my pharmacy colleagues, as well as other colleagues, have been, and Alison's a big ambassador of LADS as well, looking at this data to find out more about every life matters, and knowing that actually a lot of these patients may end up in hospital, and we want to prevent that. So emergency department visits is something that we proactively want to reduce, and we can get this sort of information across North West London at the moment. Having said that, a lot of areas across London can also get this sort of information with regards to SABA over-reliance, or looking at your ratios of metered dose and dry powder inhaler prescribing. What was interesting is some of the information I could gather with in our teenage population, for example, that where having an option from going from a metered dose inhaler and spacer to a dry powder inhaler device, finding the right device for the right patient, was something that we've been exploring as well. ICS potency, stepping patients down to the right strength for the right severity of the person's asthma, looking at wider determinants of health, smoking and secondhand smoke exposure would be of interest to us. And of course, a lot of education and upskilling, which has been the whole theme of baby asthma, the baby steps to asthma right care, upskilling 45 primary care networks, as many, not just pharmacists, but a lot of our nurses and GPs, as well as other colleagues, to upskill themselves to start those sometimes uncomfortable conversations. Prednisolone prescribing is something that we've also been exploring, and this is trying to identify where some practices or some PCNs, we could look at the data and see where maybe there's some more urgency and attention required, and that's again something that we've been exploring. So this population health type of management has been something that I think has been really useful to identify those patients at high risk. Tools, you may have heard, some of you may have been at the primary care sessions or other sessions. We've got lung tubes, we've got slide rules that can help clinicians as well as patients understand what is too much SABA, and when we may identify patients who are using this as daily treatment rather than as emergency treatment. These 1-hour sessions, they literally are bite-sized, just to fit in with the busy lives in primary care. But we've actually engaged with 32 out of 45 PCNs so far. And for those who are really engaged as well, we'll do follow-up sessions as well. So this is just what was in the introductory slide that Alison was going through, which just gives you a bit of an overview. We're looking at things like safer labeling. The amount of times we see things like 1 to 2 puffs of your salbutamol 4 times a day when required isn't appropriate. Actually, why not have something along the lines of 1 to 2 puffs for wheeze, for chest tightness, for breathlessness, or for cough, and seek urgent medical help if the salbutamol is not lasting 4 hours. So there's still lots of different messages we could get, but need to be succinct. And engaging with community pharmacies as well to ensure that this education and upskilling is consistent from both sides, really from primary care and community pharmacy. Encouraging patients, and no, not patients, clinicians, really, to get on the journey of learning the national bundle of care. Tier 3 is something that we're really aiming to try and get as many of our pharmacy colleagues working in practice and who are actually supporting patients with asthma. They need to have the knowledge, but of course the skills. And Alison was alluding to a lot of the work that we've been doing with MDT skill work and a lot of face-to-face sessions. So we try to do to keep that confidence and skills up as well. Other things that we'll be looking at during the training. And by the way, this support started back in October 2021. So we've been doing the Children and Young People's Asthma Network across Northwest London. We've been proactively trying to minimise the risk and prevent future asthma deaths, but not only deaths, but also help people live better with asthma, reduce morbidity as well. And we've been looking to evaluate this and look at the data to see if these certain metrics are improving. A lot of the work has been looking at sharing the London Asthma Decision Support Tool data, which is really up to date because EPAC2 or open prescribing is normally 3 months behind, whereas LADS data is updated every month, and we can see live prescribing data. And we normally send out, or I've been sending out a lot of messages to keep a lot of the PCNs up to date on how they're doing on certain metrics. This particular metric is identifying patients on 6+ SABA over a sort of 12-month period. We can look at the data over time, and this is looking at, for example, EPAC2 data from October 21, where I, for example, started my role, and it showed around at that sort of time we had around nearly 19.39% of patients on 6+ SABA. That percentage should really be 0, but the average of the population nationally is around 25% at that time. And up to June 23, we've managed to reduce that to around 15.34%, really striving to get towards that 0 mark. And the London Asthma Decision Support Tool gives us information about ICS adherence as well. And so this circle in red highlights that nearly 57.4% of patients are getting less than 5 inhaled corticosteroids over that 12-month period. And why I'm interested is what's the impact on children and young people, because this is all ages. So we can use the filters to actually go down to different age groups. And of course, we can use other data, like most of you across London can look at EPAC2. And we found actually this particular metric wasn't particularly good. And what we want to do, of course, is learn lessons on where we can make improvements on improving adherence amongst all ages. But I'll show you some information around how we can access that for children and young people across Northwest London and Southeast London, where we have access to LADS. Some of the training involves conversation starters around, when we're running some group consultations. What I tend to like is having my lung tubes around. Alison likes the lung tubes as well, uses them a lot. Just showing where the blue inhaler, for example, works on the outside of the airways. But one of the metaphors we like to use, and this is something we used from colleagues from Spain. Imagine your house is flooding. What would you do? Would you use a bucket to get the water out if your house was flooding, or would you call a plumber to try and fix the problem? When we're trying to describe the airways and how each inhaler works. And some of the kids say, I like the idea of the bucket to get the water out, but it stimulates conversation on how they can become their own plumber in fixing the problem and using regular doses of their anti-inflammatory inhaler, for example. So there's lots of different illustrations we can use, as well as lung tubes, to get the point across. But I just wanted to show you as an example across Northwest London. This is for all age groups, 59.9% getting less than 5 ICS. We can also look at prednisolone prescribing and ICS adherence. You can see that across the bottom with regards to the number of ICS prescribed across Northwest London. You would want to see that go up. This is in adult population, 58.2%. But look at children, 72% of children and young people not getting regular use of inhaled corticosteroids. So this is obviously, the work is not done, the job's not complete. We want to obviously prevent things like, more, as I say, poor morbidity and mortality. We don't want that sort of thing to happen to our population. So it's great that we've got this resource to hand, and we can implement some programs to actually prevent, to improve this. This is just an example of some of the group clinics we've been doing in one of the practices where adherence wasn't that good. For example, we found that we had quite a large teenage population. So we're encouraging use of dry powder inhalers in some of those patients where we thought it was really good. And Alison spotted one patient that had a spacer with a mask on, and she was far too old to have a mask at that age. And also, I think it was a wrong spacer as well. But just to really highlight, again, we're really pleased with this sort of metric. I mean, this is not just numbers here and metrics. This is people's lives living those breathless moments. We're noticing 8,962 less SABA prescribed since October 2021. That's great news with regards to not only the patients, but also the environment as well. As a lot of us know that the impact excess waste has like this on these inhalers have on the environment. Just to follow up on, if a PCN wants that second hour of training, we really focus on the audit work that they can do. We've got pharmacy technicians on board as well with regards to a lot of these audits and work, and starting and practicing that uncomfortable conversation when somebody requests that blue inhaler, and it can be very uncomfortable at times. So having all those tools to hand has been really handy, and hence why I think we're doing particularly well on this metric. But as I say, lots of work still to be done. I'll pass you over to my colleague, Alison, to wrap up.
So I think, hopefully we've been able to share with you some things that can be done at ground level. All of these things take time, but as I think we've illustrated, these are small steps, baby steps, working up towards improving the care and optimizing the treatment that a lot of children and young people with asthma have. Trying to implement behaviour changes to more colleagues, that's some of our next steps. And, we're working very closely with lots of pharmacists working within PCNs, and many of them now have taken this one step further in relation to their own practice and have become asthma champions within the GP practices within which they work. We are measuring and monitoring very carefully the impact of the things that we're doing. And I think certainly where this has been embedded and we've been able to build such positive relationships, not just between primary and secondary care, but also between education, we're noticing the positive outcomes. So I think Darush, showed us the pictures of the group consultation. The GP had been really innovative there and had contacted all of the local schools, and those children were given a half a day off school to come to that, because the school recognised how important it is to actually get children and young people's asthma better controlled, because it increases school attendance and has an impact on the acute presentations. And I think, certainly I can't say the numbers are huge in terms of diminishing numbers of children presenting to hospital, but we are starting to see a decline. But it's that network of people working across all of these different domains, and our focus in terms of building relationships and having that backup and continued updates. There's a peer support network in place with all the pharmacists that we've worked with to date, a community of practice, and the attendance at the PCRS conference with a group discount for all of those people who will be attending. Darush has mentioned the National Competency Framework, the Tier 3 training, and certainly that's something, having done it myself, it's exceptionally thorough, it's really good, and it's free. So we're encouraging all of our colleagues across all of the different domains to complete that. And even those in education, completing Tier 1, and if they're keen, Tier 2. So there is obviously, as I think we've shared, a senior nurse support and mentorship in practice where we can go out and we can work with colleagues in primary care, and we've got more group consultation sessions planned, and they are really exciting. I'd never been involved with them up until recently, but they are enlightening, and you can have, make really significant changes and differences. Next slide, please. So I think, and I hope that that summarised the work that we've been doing across North West London. Happy at the end of everybody's presentations to take any questions that people may have. But on behalf of Darush and I, thank you very much for inviting us to share what we've been doing.
Oh, thank you so much. I know I've got 101 questions already, so but I know they've got to be left till the end. Just in terms of time, I want to hand straight over to Reena Patel from South East London, LPC, pharmacist by trade, I believe, but she's going to tell us all about the incentive scheme that is happening down in the South East. Reena, over to you, and thank you very much. I know we had problems with your camera earlier, but it's great to see you on screen. Take care.
Thank you. Yeah, hopefully you can all see me now. So yes, I am a community pharmacist and I am a support officer for the local pharmaceutical committee. There are 2 within South East London and we run across both of them at the moment. So I'm here to talk to you today about the children and young people asthma service that we had in place, which ran actually last September through to November, and just to sort of tell you a little bit about what was involved in it and how we got on. We decided to choose that particular time of year in order to do this service, just so that we could proactively support the cohort to reduce exacerbations and improve patient outcomes right before the winter sort of really kicked in and made things worse. Can I have the next slide, please? So just a bit of background really into why we decided to go about this service. In South East London, there are nearly 30,000 children and young people being prescribed inhalers. And poor management of asthma, including non-adherence and over-reliance of rescue medication, increases the risk of adverse outcomes and loss of control. And there's clear evidence that shows that regular planned care for patients with asthma reduces the risk of exacerbations and improves quality of life. And also we were looking at the SABA metered dose inhalers to see the environmental impact and making patients aware of this. So the service was designed with the CCG, as they were then, along with the LPC. It was a good collaborative event. We developed a task and finish group that met regularly. And we were then able to formulate the service specification, develop a contract, SOP, and the DPIA, which is the Data Protection Impact Assessment. There were some challenges along the way with this and lots of new skills picked up and learned along the way, but it definitely helped to have everybody on board with this. Can I have the next slide, please? So The cohort for this service was 5 to 18-year-olds. We sent out expressions of interest to all of the community pharmacy contractors across the whole of South East London. And collectively with the CCG, we decided on 36 pharmacies to take part in the service. And we chose them based on the fact that we would have a good coverage across the whole of South East London, as well as looking at some of the more deprived areas. The pharmacies were required to undertake training on inhaler techniques, the basis of asthma care and medicines optimization principles for asthma. The training for this service was all made available via the CPPE learning platform. And the pharmacies needed to sign off a declaration of competence to say that they had completed these. They were required to proactively contact the patients and arrange appointments with them over the phone. And we specifically said that the appointments needed to be done face-to-face because we were looking at inhaler technique as part of this intervention. We used an IT platform called Pharma Outcomes to record the interventions, and the pharmacies were paid for every 15 interventions that were completed. So after this 3-month period where we ran the service, we managed to do a total of 681 interventions. If I could have the next slide, please. So just to give you a bit more sort of detail about what was involved within the intervention. So like I mentioned, we asked that inhaler technique was checked at every contact, and that spaces were provided to those children and young people that did not have one and required one. The spaces for this were funded through the scheme, and the pharmacies only needed to inform the GPs so that it could be added to their records, but they didn't require to get prescriptions from them. We also looked at making sure smoking cessation advice was given to the children and young people if needed, or to the household, and also looking at excessive and underuse of SABAs, ICSs and oral steroids. And if appropriate, referred back to the GP. We also talked about the environmental impacts of overuse of the SABAs as well. And of course, throughout, it was signposting to further information for support as and when was needed. So if I could have the next slide, please. So I'm just going to talk through some of the findings of the service that we had. So from the 681 interventions that were made, you can see that 59% of the cohort were male, and that 63% of those were aged under the age of 13. If I could look at the next slide as well, please. You can see here there's the breakdown of the ethnicity and by the CCG. So with the ethnicity, there was a high proportion of white British, but you can see there is a spread across all other ethnicities. But unfortunately, we did have a high proportion that did not state or preferred not to stay. So we couldn't draw any strong conclusions in terms of using this as any sort of demographic information to help us in that way. We also looked at the breakdown according to the different areas within South East London. So there are 6 boroughs, and we looked at the breakdown accordingly. So the highest rated for where patients lived were in Lewisham, Bromley and Greenwich. There was a small proportion, you can see there, there's 3% that had come from other boroughs. And that's because in community pharmacy, anyone can go wherever they want to. There's freedom of choice. It's not like with your GP surgery where you are registered and have to stay. So we do find that we do get people coming from other areas as well. If I could have the next slide, please. So this next slide is quite interesting because it's something that we asked throughout the programme to say who was actually responsible for the asthma. So we had it under, you can see on the slide there, it talks about the different classifications. So we've got me, the asthmatic, which means that they don't need prompting to use it. They can attend GP appointments on their own if they need to, collect the medication from the pharmacy independently, me and my carer. So the carer might have to help with prescriptions and appointments, or my carer alone, which means they need regular support. So it was quite interesting to see that there was quite an even split, despite the fact that we're looking at such a young population. It was good to see that there are so many people that are invested in their own health and actually starting to take responsibility for their asthma as a whole. If I could have the next slide, please. So during the interventions, 92.8% of all patients seen had their inhaler technique assessed, and 63.6% already had a spacer and were using it correctly. We did actually provide 92 spacer devices throughout the scheme, and as I mentioned before, they are just reimbursed through the scheme. There was no need for prescriptions to be made available for this. However, we did inform GPs that spacers had been provided. If I could have the next slide, please. So the use of SABRs and ICSs were discussed with all 681 patients, and 40.3% of the interventions required referrals back to the GP. And this was either due to poor adherence or underuse of the ICS, which was deemed as less than 6 collections per year, or due to overuse of SABRs, which was deemed as 3 or more prescribed within a rolling 12-month period. Those with the higher SABR use were also informed of the environmental impacts that this could be having and what they need to do in order to try and help reduce this. A high proportion of interventions asked if the patient had a personal action plan in place, but unfortunately, we were unable to capture the actual answer as to whether or not they were there, which is something that we would look on improving if we were able to run this service again to find out the actual proportion that did actually have an asthma plan in place. If I could have the next slide, please. So 20 of our 681 patients were highlighted as actually being smokers, and 77 had someone smoking within their household. So we were offered smoking cessation advice to all of these and signposted them to services that were available to them both locally and nationally. If I could have the next slide, please. So in summary, the service proved to be of great value during this time frame. The pharmacy teams were under immense pressure, as always, as the start of winter becomes, but they were still able to deliver a high quality service to a large proportion of people. But it was important that we chose this time of year because we wanted it to impact on the patient in the most significant way, because we know how detrimental winter can be for these asthmatic patients. The pharmacies also reported to us that the freedom to be able to provide the space of devices during the intervention allowed it to be more impactful and save time and resources than if it were to be prescribed, because that would then involve having a further intervention with that patient to then go through how to use that spacer and counsel them on the uses of it and when it would be appropriate. So if I could have the next slide, please. So before I finish up, I would just like to sort of inform you about some other things that are happening within South East London. And one of them is this inhaler recycling scheme that we are looking at. So the LPC are working closely with the ICB and NHS England on this project. It will be a pilot project to recycle the HFA gases that are found within the metered dose inhalers. And we're looking to have those gases recycled into coolant systems for things like fridges and air conditioning units. The metal from the actual canister and the plastic surround to help deliver the medication can also be recycled. So we are looking into having the company do all this process for us. So the way that it will work will be that the patients will pick up their medication from the pharmacy, whether that be within the community pharmacy or hospital pharmacy, and they will be informed of the scheme and encouraged to return their unwanted used inhalers back to the pharmacy or to the hospital site. Once they are returned, they will be segregated from the other clinical waste that is returned to pharmacies and then sent for processing in order for this to be recycled and for us to get some data from the company as well. So we are hoping to receive data as to how much HFA gas has actually been recycled and repurposed, along with the metals and the plastics, and also work out how much we have done with our carbon emissions in the actual process of the recycling. So we're trying to see whether or not we can make this more efficient a process. It's very, very early stages still in terms of how this is coming about. And we are working out lots of different steps as to what's the best way and costing up different models. But I just thought I would inform you that there are some new and interesting bits on the horizon for us. If I could have my last slide, please. So thank you very much for having me here today. I really appreciate the invite and your time taken to listen to me. If you have got any questions or comments, I'll be happy to take them within the chat function. Thank you.
Thank you so much, Rena. Really good presentation, really appreciated, and good to hear about the recycling at the end of that. I'm sure a lot of people will be very interested. I'm going to quickly hand over to Sukeshi, a good friend of mine who I've known for many, many years, but it's me who's old and not Sukeshi. A paediatric respiratory pharmacist, consultant pharmacist by trade, and she's going to talk to us about the discharge management scheme. Thank you to Sukeshi.
Oh, thank you for that lovely introduction, Steve. And thank you to Ask About Asthma team to invite me to speak about the discharge medicine service. And effectively, what I'm going to talk about is just give you a little bit of a background. You may already know quite a bit of this anyway, but just to get everyone up to speed. And then talk about a really interesting case that I had where the discharge medicine service was really effective. Next slide. Yeah. So the discharge medicine service is, as it says, discharge from hospital. And we know that discharge from hospital is associated with increased risk of avoidable medication-related harm. It can increase admissions. And we know that the World Health Organization has actually made this one of its aims to reduce avoidable harm from medication by 50% over the next 5 years. And this is in their document, Patient Safety Challenge, Medication Without Harm. Issues with medication arising at discharge are often due to poor communication or no communication between different healthcare providers. And largely that's often been due to digital technology and the ability to communicate. But we do know that there are benefits of really having good communication between different sectors. And NICE guideline have stated that in their recommendations have said that medication-related communication systems should be in place when patients move from one care setting to another. Medicines reconciliation processes should be in place for all persons discharged from a hospital to another care setting, such as primary care. And the act of medicines reconciliation should occur within a week of discharge. Next slide. So the DMS service is considered to be an essential service for community pharmacy contractors. It commenced on the 15th of February. It is within their contractual framework, and it was established to ensure that there is better communication of changes in patients' medication when they leave from one care setting to another, usually hospital to primary or other care. And actually, the good thing about this was they recognized community pharmacists and pharmacists as providers of improving education, outcomes, and prevention of medication harm. So we were highlighted as being instruments in improving this and reducing medication harm. It came about in the NHS Pharmacy Regulation Guidance in 2020, and NHS England and NHS Improvement published a guidance with regards to this, which was introduced nationally. Next slide, please. So within the DMS service, and the components of the DMS service are a toolkit, and basically this toolkit can be used to help implement the DMS processes, and it gives guidance for hospitals, PCNs, and community pharmacists. Clinical teams within the respective organisations need to have ensured that they've read this, they are aware of the toolkit, and they fully understand their roles and responsibilities when delivering this important service. There is a CPPE training material on this, but it relates largely to adults. However, quite a lot of this is transferable to paediatrics. And when it first came about, there was this myth that it was only for adults, but actually we are using in pediatrics, and pediatrics are the people that really need this. And is really important for us. It was first introduced as the TCAM project, transfer of care around medicines, and one of my colleagues, Marsha, was involved in this, and it used the platform Pharma Outcomes. So Rena quite nicely introduced or led me into my presentation. And the Royal Brompton was involved in the pilot TCAM project, which was actually hosted by Chelsea and Westminster initially. And we started it off in adults and then progressed it into pediatrics, and we now use it not just in respiratory for inhalers, but we use it for cystic fibrosis patients, we use it for our cardiac patients, for diuretics, so that community pharmacists are aware of the formulation that we have sent a particular patient or child home on. So it's really, really quite useful. Next slide, please. And effectively, this is an infographic that shows the different people or the different sectors that are involved in the DMS service and the different pathways that are involved. So hospital, community pharmacy, PCNs, GP practices. So pharmacists from all sectors are involved in this and can be involved in this. Next slide, please. And these are the different roles of the respective organizations. There's a role for chief pharmacists to ensure that they have leadership on this, that hospital pharmacists identify patients, they consent and they refer. There's a checklist for community pharmacy contractors, and there's a declaration of competence that Rena was also talking about, and importance of patient engagement during the CPPE package, so that they are aware. And then there's information for GP and PCN pharmacists as well. Next slide, please. So, so what should be involved in our DMS service? Well, those patients that are on new medicines, we could check their understanding of medication, provide education and conduct an NMS, talk about side effects, talk through how it works, medicines optimization, understanding the benefits, so that checking that patients are aware of the benefits, medicines interactions and checking that, are they on herbal medications that interact, and they think that herbal medicines are not harmful, different foods, vitamins, medication disposal, which Irina quite nicely talked about, inhaler schemes, needles, syringes, adherence support, really important, all the information that Darush and Alison were talking about, and importance of taking medication, and less reliance on SABAs and improvement on ICSs, and additional resources as well. Next slide, please. So I'm just going to talk you through a patient that I had. Of course, they're disguised as DA. And I just want to demonstrate to you how useful the DMS was to me. It only related to one inhaler, but it caused lots of problems and issues. And I'll go through that why. So I had a child, DA, who was 12 years old, weighed 35 kilos and height 146 centimeters. Always important in pediatrics to know the height and weight of the child. So what was their diagnosis? They had a severe eosinophilic asthma, so severe asthma. They had really bad eczema. They had recurrent lower respiratory tract infections and were on azithromycin prophylaxis. They had adrenal suppression, largely due to the high use of oral corticosteroids, and the steroids were used not only for the asthma, but also for the eczema. And they were actually on a 6-day hydrocortisone supplement, and I'll go through that. They had gastroesophageal reflux, and they had lots of multiple food allergies. And although this seems quite complex, you will see it only related to one inhaler. So what happened? They kept on coming with exacerbations of asthma. And believe it or not, they were non-adherent to their seretide. They were high SABA users, so Darush would have identified him in the lab's dashboard, and they were a high OCS use again, could have been identified in the lab's dashboard. Next slide, please. So what was their drug history? They were on seretide, salbutamol, and yes, I shouldn't be using 2 or 3 puffs when required, should label it appropriately. They were on omalizumab, which is a biologic, and so you could see the severity of the asthma because they were on a biologic, which they were using every 4 weeks. They were on lansoprazole for their gastroesophageal reflux, azithromycin that I mentioned earlier, and the hydrocortisone for 6-day rule. So 10 milligrams in the morning, 5 milligrams at lunchtime, and 5 milligrams in the evening. That is what they would use if they fell sick with a cold or anything like that. So what did we actually do? They came in for an outpatient appointment, and the my consultant, decided that there's too much use of salbutamol, not really adherent to seretide. So let's think of Symbicort MART, so maintenance and reliever therapy, because we're aware that budesonide and formoterol, all the trials show quite good efficacy and reduction in asthma exacerbation. So one device that does everything, maintenance and reliever. And what she decided is that she would go for the MDI, Symbicort MDI 206, 2 puffs twice a day with additional doses as needed. And now I'm hoping that a lot of you are thinking, Symbicort 206 MDI, does it even exist? And if it does exist, what is it used for? Because that's what I thought. But it does exist. However, it is only licensed for COPD, not even asthma, and it's not even licensed for use in children. So herein comes the first problem. Second problem, we didn't have it in the hospital. So we decided we would be clever, we would change it to 103 MDI, which is licensed at 3 puffs twice a day, and then NMS. And at that time, I didn't make an NMS. I just let the patient go home on it and assumed it would happen automatically. Next slide, please. So when he left, when he left us, our outpatient clinic, his FEV1 was 2.36, which is 87% predicted. FVC was 2.65, which is 97% predicted, and his FeNO was less than 5. This is very good for him, yeah. In October, he was prescribed a Symbicort Turbohaler 206 because Symbicort MDI is not licensed for asthma, it's not licensed for children, and it's only licensed for COPD. In November 22, he had a video appointment with one of our CNSs, our nurses. He was unwell. His FEV1 on the home spirometer showed an FEV1 of 53%. See the drop. His saturations were 89 to 94%, but they fluctuated, and he really was not well. He was sent to A&E. He had nebulized salbutamol, oxygen-driven, IV magnesium, started on oral corticosteroid. However, no other changes were made, and was sent home with oral corticosteroids on discharge. He eventually came to us, and I decided to make a discharge referral because mum was trying to use a Symbicort Turbohaler. Sorry, I forgot to mention that mum was using Symbicort Turbohaler through the spacer, and this is why it was ineffective. She was just trying to use the wrong device through a spacer. And so I made a discharge referral, spoke to an excellent community pharmacist who made sure that the Symbicort MDI 206 was prescribed, and explained it all to the GP as well. I phoned the GP about this as well. Next slide, please. So what were the main issues? They were prescribed Symbicort, which is not licensed. It's not licensed for MART, not licensed for asthma, and only for COPD. Yep, almost to the end. We sent a letter that stated Symbicort MDI 206, but the hospital gave 103, didn't make the NMS. And our issues were that this child was non-adherent. They had ASD, which is why the consultant wanted the 206, because one dose would have been enough for him. There were safeguarding concerns. He was a high SABA user and a high OCS user. Next slide, please. So in summary, it was one simple change of an inhaler, and yet he had an exacerbation, and there were so many issues with regards to this. The community pharmacist, by doing the DMS referral, the community pharmacist organized and corrected the prescription every time, explained the situation to the mum, educated the mum, educated the GP. He's doing much better now, but we had to change his omalizumab to dupilumab, which is also useful for his eczema. And I just wanted to show you the powerfulness and the effectiveness of a DMS and MS service, and how important this communication is between the different care providers. Thank you for listening to me and for giving up your time today.
Thank you so much, Takeshi. Could everybody come back on screen, please? That's okay. We've got hopefully just a bit more time for a couple of questions. The chat has been frantic, trying to listen and type away, but thank you very much, everybody. Takeshi, just since you've just finished there, can I just come to you quickly? I'm going to say, how many people are actually sort of offering the discharge management service now? It's something we've been talking about in pediatrics. It's obviously really central to what we could offer for asthma, and yet I'm not convinced that a lot of people are taking it up. Can you just have a quick chat around that, what you know?
Yes, so no, it hasn't been taken up hugely, largely because of resources in hospitals and in community pharmacies, and everywhere really. And yeah, the uptake is not that great. It is powerful, but it's not that great. But I know that my colleague Ashifa Trivedi and Afak Batty are currently writing a paper in the PJ that highlights how useful patients found this, and hopefully that might make a difference. But yes, resources and also having the right platform to do it on. We were lucky, we had far more outcomes, but not everyone has this available to them.
Thank you. That was my understanding, and I think it's an amazing service that we could make far more use of, particularly with asthma. So something for us all to think about. Darush, Alison, I think there's something about how do we get pharmacies more involved with children and young people's sort of asthma care. There's what can we take from parents and the way they feel about asthma for their children? Is there something about the use of steroids and things like that? Some of the stats that you gave, which would indicate that pediatrics are worse than adults in terms of getting. And where can pharmacy really get more involved with trying to sort that out? Is it that explanation of or encouragement that corticosteroids inhaled are not the enemy? What is the approach? Can you just go through that a little bit?
Yeah, just if I start, Alison, you can if there's a different approach you use, but a lot of it is around the word communication we use. I think with and the time you spend actually educating patients around what asthma is, what the medications are, and giving them an opportunity to ask questions. I think it's a whole thing of going back to ideas, concerns, expectations. But some of the tools that I've been trying to help colleagues with is using the words Professor Rob Horn, for example, uses around that we're using the balance model. So we all naturally release steroids in our body, and how our lungs may react too strongly to certain triggers, and trying to get that balance restored by using a very low dose of this anti-inflammatory type of treatment. So using Right Breathe as well, which is a good website which shows traffic light signals of green, amber and red to show this potencies and strength. This is very useful in adults actually, because Right Breathe shows the adult potencies, but it could be better with using the children and young people ICS potencies as well. Just to, and highlighting, of course, that these strengths are far and the side effects are far less than having to take a course of oral corticosteroids is emphasized as well in a huge way. So it's just those sorts of conversations, and self-management plans are a key part of that as well, and co-creating with the patients so they understand that. And I think that's something that unfortunately I think sometimes gets rushed in consultations, and we need to make sure we put that quality time in.
Yeah, it's how to put the time in, isn't it? Alison, anything to add there?
Yeah, no, I would just agree with Darush. I think one of the fundamental things is about communication, explaining things in a language that children and families and parents understand, and actually trying to explore some of their worries and concerns. Why is it that the child isn't taking the inhaled steroid? Are there particular reasons why? And then going on to reassure and explain the facts, because very often parents are worried about the children are going to have stunted growth. There is just no evidence to support that with the doses of inhaled steroids that we use for children and young people with asthma, but it's having that opportunity and time to be able to go through that so that at least, they had that understanding of the real truths.
Thank you. Rena, if I could come to you quickly, are there plans to roll out the work that you've been doing? It's I'd hate to say, obviously coming from north of London now, although I was south. Are the southeast leading this bit now? Oh, yep.
Yeah, for now, everything unfortunately is in pilot phase, and we are just trying to get the data through in order to see whether or not things can get rolled out to a wider picture. Unfortunately, it will be across the whole of southeast London first before it can look to be going elsewhere. But we are working with local universities to get the pilot work that we're doing evaluated to a higher level, so that we can use that to try and put forward a case for things to happen on a larger scale.
Thank you. And I think a bit like the recycling, there's a lot of things in pilot phase at the moment, which will hopefully move forward. Just on that sort of sustainability front, I think it got mentioned, and there's a lot of work been done on SABRs and the fact that they are not great in terms of sustainability. I'm wondering how that conversation happens in terms of, is it an effective tool when talking with parents? Yeah, but basically, we do know that salbutamol, MDIs, you know, they are probably one of the worst things that we're doing out there. We're certainly in secondary care, everyone's looking at their gas supplies, and the next thing is salbutamol, MDIs. Is the sustainability discussion one that is working in terms of people sort of picking up? That's open to anybody who'd like to come in.
I'm not 100% sure from the children and families that I work with that that's even registered with them, if I'm honest. But I think, you know, certainly, as Darush alluded to earlier, when we did the group consultations, it certainly did come out in conversation. And actually, a lot of the young people that were there, we switched them off of the SABA MDIs onto MART. And they were all very happy. I think it will optimise their asthma control significantly, as well as help us with our carbon footprint.
Thank you. Anybody else wants to throw anything in on that one?
Just a headline that I mean, Sakeshi and I and the obviously the NHS England London group, the pharmacy subgroup, we've been doing a lot of work on this, and I think a big headline there was good asthma control is good for you and good for the planet. So that was really our sort of main headline message when we're bringing up and knowing that one SABA inhaler, one salbutamol, one of these blue canisters, if you've got good control, should last you 6 months, ideally longer than that. But you know, anything more than 2 a year, your asthma is not fully controlled. So it's really emphasizing those points and illustrating it and holding these canisters in your hand to say one should last you 6 months. And there's disbelief in their eyes. No, I need more than that. You know, so it's just really getting that message across that this is not going to treat the asthma. It's only going to, it's good for those emergency situations.
I think from my point of view, I do find that children or adolescents are more engaged with this than their parents. And I had a parent that said to me, because I wanted to change them from Ventolin to Salamol, very easy. I said, oh, can I, are you aware, carbon? And she said to me, who do you think is more important, the planet or my child? So I was like, oh, this is a bit difficult. How do you answer that question? But if I went off and talked to the child, it's totally different. It's a turnaround. Of course, I care for my environment. Of course, I want to do something about it. And of course, the advantage of MART is just one inhaler does the whole thing. Beautiful.
Thank you. That was really useful. But yeah, it's always interesting. The balance between your child and the planet. Difficult conversations. And I'm aware that we're just over time, but one other point which came up, and I'm just going to ask, and it's probably straight to Darush, this one, the approach of smoking cessation, which fits in with all of these topics in some ways, but still a really big topic with children when parents are there. Often it's not known whether children are smoking. There's obviously the whole issue about people smoking in the household, but there's children smoking and young children smoking. Any words of wisdom on approaching that? I know this is a topic that I got quite involved with in a slightly previous life, but I think it's a really important topic and quite a difficult one to sort of negotiate. Any words of wisdom?
Yeah, I mean, following the evidence-based 30-second model is something that I always have in the front of my mind, which I'll go through. But just to give an example, Alison and I, when we were running group consultations, Alison was doing peak flow readings, and I was doing carbon monoxide readings just to check to see if there's been any exposure to carbon monoxide, which you can get from cars, buses, faulty boilers, but also from cigarettes or secondhand smoke. We found none of the children were smokers, even though some of them were older children, but we did find some of the parents were smokers. But the approach was to ask if anyone smoked or anyone smoked in the household. I don't always jump in a pharmacy setting. I never say, do you smoke? I would ask, does anyone in your household smoke, or do you smoke? I'll do it in that at that angle, and advise the person that the best thing you can do, of course, is we can offer support and treatment in NHS where you're 3 to 4 times more likely to stop. How dare you accuse me of smoking? You might get back, but it's a positive, it's prescriptive, but it's positive. Did you know, do you smoke? Did you know the best way to stop is with support and treatment? And if they say they're interested in stopping, then signposting to what's available. But that carbon monoxide machine is such a motivational tool. And if anyone gets any of those elevated readings, and so when you're doing your sort of lung health check day or that type of, and I think during the pandemic, it sort of stopped for a while, but now we're really introducing it again as a routine part of our sort of group consultations. And it's a similar maneuver to blowing into peak flow, except you're not blowing in as strongly as peak flow. It's like you're blowing up a balloon is the way you would describe this one. And show them where they are on the chart. Have a carbon monoxide chart just to show exposure.
Thanks, Suresh. I've just picked up on something that's just gone straight into the chat about, obviously, far more to do with vaping, possibly these days. I will just say I'm just talking to Catherine Tulu, who does a lot of paediatrics at the School of Pharmacy, and we're looking at a piece of work in terms of research around vaping and the excipients in vapes and what all of that does. I'm going to say negatively to us rather than positively. I mean, we might find out there's something positive in there, but we're not expecting it. And so we're just about to embark on a big piece of work around sort of the contents of different vapes and bits and pieces. I'm going to finish it there. I realise we're over time. Thank you so much. I've literally scribbled down about 30 questions on my sheet of paper here, and I realise, and I might have to ask you after this. But first of all, a big thank you to everyone who's organised this. Big thank you to our speakers, but also a huge thank you for all of those who have joined tonight. And I hope you have found it really inspiring, and also some words of wisdom that you can take away with you. Really appreciated. Thank you and good night.